Hi, this is Dr. Neurosurgery Greenberg. Today we'll be discussing Cushing Syndrome. But before we get into it, I would just request all of you to please like, share, and subscribe. And please follow me on YouTube as well. And whenever you comment or like my videos or subscribe to my channel, it gives me more confidence to make and motivation to make more videos like this. And also, if you have any query, anything you want to ask, please do give me a message or to just write a comment, and I will try to address that concern in the next video. And I'm really hoping that you are going to support me in this venture. So let's start with Cushing syndrome. So the first thing that you need to do whenever you see any cellular supracellular mass is to assess whether the patient has enough cortisol in the body or not. By enough, I mean that if any stress is put on the patient, will they be able to rise to the occasion and produce more cortisol or not, like infection or surgery. And I've done a very detailed video previously, and if you haven't seen it, then please do check it out. Here I'm going to give you a brief overview of the whole thing. So the first thing we do is the co-syntropin or the ACTH stimulation test. So it's not the gold standard, but it is a very useful test. So what we do is we take a baseline cortisol level, and then you give the co-syntropin or the ACTH. Normally, in a normal patient, if you give the ACTH, the cortisol will peak. So we know that the cortisol level in the body is 6 to 18 micrograms per deciliter. And if you give the ACTH, then you get a very high peak, more than 20 microgram per deciliter. Or you got the cortisol level was more than 18 microgram per deciliter, and from the baseline, an increment of 7 microgram per deciliter was observed. So this means that the patient has a normal ACTH cortisol relationship. If not enough cortisol was released and the levels have not peaked, then it means that the patient, no matter how much ACTH comes, the patient is unable to produce the cortisol needed for stress, needed for infection, needed for anything. Even the patient is dependent on the steroid. So you have to give exogenous steroid in this patient. Now, this test only tells you if enough hypocortisolism is there or not. For hypercortisolism, we will do other testing. And after that, we have insulin tolerance test. Again, I must emphasize that co-syntropin and insulin tolerance are just whenever these tests are just to see if the patient has enough cortisol or not. That these are the first tests that you do whenever you see any cellular, paracellular, supracellular mass. You are going to do these tests. Okay, they are not for Cushing syndrome. Cushing syndrome means that the cortisol is very high, more than normal. Whereas these tests are going to tell you, okay, whether the patient can needs any exogenous steroid or not, and can he undergo surgery or not. So the gold standard is insulin tolerance test. What you do is you are going to check the integrity of the whole hypothalamic pituitary adrenal axis. Okay, you're going to check all three. So what you do is you stress the body. You create hypoglycemia. How much? Less than 50 or less than 40 milligram per deciliter of hypoglycemia you have to create. Now, obviously, if the patient has seizure history, or if the patient has heart disease or hypothyroidism which is untreated, then the patient can die. So you will not do the test in these patients. Okay, and you have to prepare adequate dextrose. You have to prepare another peripheral IV line, so that if the patient cannot produce their own cortisol to counteract the hypoglycemia, then you can give the glucose and the patient doesn't die. Okay, so it's a very tedious kind of a test, and it's dangerous as well. So you give insulin up to a point that the blood sugar of the patient comes down to less than 40 milligram per deciliter. After that, you check the cortisol level. You took a baseline level and now you will check if the cortisol has peaked or not. So if the in the normal patient, the cortisol will give a peak of at least 6 microgram per deciliter from the baseline, or it will peak to more than 20. But if the peak is not coming only 16 to 20 microgram per deciliter, then you just need to give stress dose of steroid. That is for surgery, that is whenever infection happens, you give steroid. Otherwise the body is capable. And if the peak cortisol is less than 16 microgram per deciliter, then the patient has to be put on steroid. Okay. And in Cushing syndrome, the increment will be less than, because Cushing syndrome already has cortisol, enough hypercortisolism, so it will not produce any peak. Already the body has a lot and lots of cortisol, so it is not going to peak at all. And that is what all that you need to remember. Now, coming to our topic, which is Cushing syndrome. So first of all, we have to check whether hypercortisolism is there or not. So for Cushing syndrome, first of all, you need to know the normal responses. So we know that CRH is secreted from the hypothalamus. It stimulates the ACTH from pituitary, and ACTH causes more cortisol to be released from the medulla. Now, what will happen is that if you give steroid to the patient, then the ACTH will be suppressed, because CRH will sense that the body has more steroid, so no more cortisol needs to be produced, and it suppresses the ACTH, leading to a negative feedback, and it will reduce the urinary as well as the serum corticosteroid. Now, in the cases of Cushing syndrome, what will happen is that if you give some kind of steroid, you give low dose steroid, and you do the overnight low dose dexamethasone suppression test, right? And remind you, you are doing this in a patient with Cushing features like moon faces, like a pendulous abdomen with purple striae on it, peripheral limbs are thin, and there is centripetal or central obesity, okay, apple shape, and then there are buffalo humps and all that, hypertension, hyperglycemia. Metabolically, there will be alkalosis, okay, hypokalemic alkalosis. So, so you did the overnight testing of the low dose dexamethasone test, and you gave a low dose which is 1 milligram at 11 p.m. and in the very next day you are going to withdraw the cortisol level in the morning at 8 a.m. Now you are going to get one of these. First of all is that the cortisol level drops to less than 1.8 microgram per deciliter. This means that there is no Cushing. Okay, the patient is normal. Okay, they are fat, whatever, but it is not Cushing. And then there is a value that is between the 1.8 to 10 microgram per deciliter. It means that the test is equivocal. It is neither ruled out, the Cushing is not ruled out, and it is not ruled out whether the patient is normal. But if the cortisol still is high, even after giving a low dose of steroid, more than 10 microgram per deciliter, then maybe Cushing syndrome is there. Here you will do the 2-day low dose test when the cortisol levels are in between 1.8 and 10 microgram per deciliter. Okay, that is the low dose dexamethasone suppression test was equivocal. You will now do the 2-day low dose test. Now you will give dexamethasone 0.5 milligrams for 2 days. Okay, and after that you will obtain a 24-hour urine collection prior to the test as well as on the second day. And then you will check the urinary corticosteroid. Normally, if you give dexamethasone, then serum and urinary corticosteroids are both lowered. But here, what will happen is that normal patients are going to suppress the urinary concentration or the serum concentration has to be lowered to less than 4 milligram per deciliter in 24 hours. Okay. So, but in the case of Cushing syndrome, what will happen is that the urinary steroid will not be lowered because the cortisol is high and it is not affected. Even if you add a little bit of steroid, it is not bothered. So, here again, you can say that the Cushing syndrome will not be lowered by whether you give the low dose overnight dexamethasone or the 2-day dexamethasone. Okay. And there is another test that is 11 p.m. salivary cortisol. Actually, at 11 p.m., the cortisol goes to a nadir. That is the trough value, the lowest value. So over here, actually the cortisol should be very low, but still if you get high values of cortisol, then it means that Cushing syndrome is present. And after this, we are going to make another video. Hopefully you are going to like, share, subscribe and do everything on TikTok as well as on YouTube so that I can be motivated as I previously asked you. So we are going to do the next video in which we are going to distinguish where the Cushing is coming from. Is it a central cause or is it an adrenal cause? So thank you and God bless.